USAID times. And the whole idea was to actually build a business case for sample registration system for Ghana. So I'm going to go through those discussions that we've had, both in-house and then the final products, where we had a business case document that I'm sure Patricia will be able to share with the rest of the team. So the business case document basically is how was Ghana going to position itself to be able to mobilize all development partners, get them around the table to be able to support and contribute to a sample registration system. And so what we basically looked at is how do we communicate this idea clearly to these partners to be able to make the case for partners to come in and support, and then also make a case, a strong case that an SRS is a platform that can be used to collect cause-specific mortality data, and then also make sure that we have readily available on-time data for decision-making and policy. And then also how do we clearly communicate the role that an SRS can play within a global health security space, making a very strong technical case for co-funding from the different partners that exist in country, as well as also creating a clear understanding that would fit the solution set that has been developed. And so we all know what an SRS is. It helps us continuously track births, deaths, causes of death in representative samples across the country. It also helps us to update our population denominators within these sampled areas, as well as creates the opportunity for us to embed other population-based surveys, as well as CRVS systems within an SRS. And so for Ghana, the challenge largely was more around what existed. So we do not have systems that currently allow the government to reliably and continuously would collect and use useful mortality data in a timely fashion. Even if you go down to the sub-national levels, this kind of data is usually aggregated within the current data systems. So cost of data, particularly for deaths that are happening outside health facilities,
Williams, we've lost you.
it happens. It happens
Hi.
every.
Williams, can you hear me?
Yes, I can hear you.
Okay. Okay, now you're back. It broke for a couple of seconds.
Oh, sorry.
You're back again.
Sorry. Yes, so censuses are also another brilliant source of mortality data. However, the challenge is that these are not frequent and they happen every 10 years. And most of the time they are limited to just the crude rates. So you find it very difficult getting cost-specific data from the census data that is being collected in the country. And of course, there are also model data that we can always get, but then of course, it's problematic to use model data for decision making and then for planning and resource allocation. We do have, as a country, different institutions put in place that could solve this problem, but this will require strengthening their capacity and then building new skills to be able to position them better for them to be able to collect data in a continuous manner that would be able to address the needs that an SRS can't address. And also there are coordination and collaboration challenges among these different stakeholders. So if you look at the arrangement in Ghana, you do have the Ministry of Health, you have the Ministry of Finance, which is overseeing the Ghana Statistical Service. We have the births and deaths registration, which is also under a different ministry. So coordination issues becomes quite of a challenge to be able to bring all of these different entities to sync and then collect data in a manner that can be used and consumed efficiently. And so looking at the gaps in the availability of mortality data across the country, this, of course, hinders how we identify problems very quickly, and then how we can prevent causes of deaths, and then also identify any emerging threats. And then, of course, at the lower levels too, we do not have that kind of data to be able to improve our policies, to be able to intervene in a manner that would prevent the growing disease burden across the country. And so the purpose is largely to look at how can we position Ghana in a way that would allow us to continuously collect reliable data that can be used at the different levels to be able to determine what the key issues are, to be able to allow us set priorities, and then also improve our policy making and monitor the impact of some of the programs that are currently being implemented across the country. And so in order to be able to implement an SRS, one of the most important things we needed to do was to be able to discuss the values and the core principles of an SRS in country. And then what would that mean for someone that would like to invest? And I'd like to mention that this particular presentation was targeting USAID at the time, who had a lot of interest in supporting within the space. And so we need to be very clear on our values and then the core principles around an SRS. And that has to do with first identifying the country's ability to be able to collect and use its own data in a manner that would help us secure health security. And then also for registration, the cause of death data production and its mortality surveillance are functions of the CRVS system. And so how do we embed these different entities or institutions to be able to make sure that those that are legally mandated are carrying out their work? But then in terms of public health agencies, they also have access to this kind of data to be able to improve public health interventions. And then, of course, Ghana being a low middle income country, we also need to think about how do we get supported to achieve the same standards that are acceptable elsewhere in the high income countries. So for instance, US government would establish very key principles for low and middle income countries, particularly for their PEPFAR program, such that all countries, as they report their data, they try to meet certain standards. How do we make sure that Ghana gets this kind of standards that are comparable to high income countries? And then sustainability was also a very important key principle in these discussions, where we want to make sure that once we get the capacity to start, institutions are brought on board, built the right capacity to be able to sustain what was going to be, what has been done, to be able to move forward, such that we would be better placed to advocate for budget allocations from the government side, advocate for co-funding from the development partners, as well as also ensure that institutions that are already doing work around mortality surveillance continue to do that in a more integrated and efficient manner. And then finally, we also looked at regional efforts. How does an SRS within the country also fit into the regional efforts? So for instance, African CDC has also implemented, has been pushing member states to be able to move in that direction to collect complete mortality surveillance. So how would we make sure that Ghana's efforts are aligned with these regional efforts to make sure that we are able to contribute data across the continent? And so we thought very carefully about the scope, the scale, and then and what it would mean to implement an SRS in Ghana. So in the early stages, the scope largely we're looking at identifying the cases, making the right notifications, and getting all of the incident births and then deaths registered within the sampled areas. And then also assigning the causes of death was a very big issue, particularly deaths that are happening outside the health facilities. And so making sure that we have a system put in place to be able to conduct the appropriate VAs, get these VAs codified to determine the causes of death was extremely important. And then also collecting this data in a seamless manner that will be sustainable across the country was also extremely important. And of course, producing this information in a more systematic, continuous manner. In terms of the scale, we're looking at a nationwide undertaking, but initially starting from a few selected regions. And the reason is largely because resources may not allow us to do a nationwide implementation right from the beginning. So we wanted to start from regions that were heavily supported by the USAID, and then we then scale up over time. USAID is no more, and so this approach would likely change, but then that has been the thinking. And then we also want to make sure that this implementation was phased out. So once we are phasing it out, we are also learning and then tightening up loose ends and making sure that we are more efficient. And then also we are integrating more sustainability measures along the way as we implement. SRS is feasible and leads to action. That we have established that. And there had been so many different examples that Ghana could learn from. We have 3 different instances here that we can share. And I think some of us who attended the covers workshop in Mozambique and then subsequently in Zambia could testify that these countries, Sierra Leone, where they implemented a Hill SL, and then we had Mozambique, we have COMSA going on there. And then we have Tanzania. I think they did something in the past. These are all very important examples that we had to use as leverage to be able to demonstrate to USAID that there are already existing examples that were successful. There are use cases that indicate that SRS work, they are feasible, and they can lead to action. And so it's extremely important that we always make sure that these examples were highlighted. Some of these examples go on to talk about how SRS were used in the past to be able to improve resource allocation. So for instance, in Sierra Leone, one of the things that they observed was that among the top causes of death, they realized that malaria or febrile illness was one of the top causes. And when they dug deeper, they realized that even adult populations were being infected with malaria, contrary to the common thinking that it's usually children who suffer from malaria. What that meant in terms of resource allocation was that in subsequent years, the government was able to allocate more resources to address malaria compared to what they saw right from the beginning. And so what that simply tells us, and we had made this case to the USAID at the time, is that using an SRS data from SRS was able to help them allocatively provide resources in an efficient manner that address a disease burden within the country, as we are seeing in Sierra Leone. Another example has to do with the fact that even in many other countries, as we are seeing the disease, more of NCDs coming up, we also realized that from the Mozambique case, NCDs were also contributing to a large proportion of the deaths that are happening. Often the data is not available, and we had indicated that in Ghana at the time that even though we talk about NCDs coming up, an SRS was better placed to be able to collect this kind of information to make a strong case that, look, the disease trends are changing and we need to begin to pay more attention to certain trends. Another big thing that we need to think about is what are the other options that existed? In Ghana, we did have the national census, which I mentioned, but there are limitations with that in terms of the timeliness, the representativeness of this kind of data. We do have the population-based surveys, so the DHS happen, the mixed surveys happen, but these happen every 5 years. We do have the health and demographic surveillance sites in the country, but these are less representative because they are localized. They are just within some particular areas and heavily researched focused. TRVS, of course, is across the entire country, but coverages are extremely low. And furthermore, they are not able to even collect test-specific or cause-specific data that would be more useful. And so there is a strong case that with an SRS, we will be able to get that national representativeness of the data. We'll be able to get that data in a continuous and a real-time manner. We'll be able to also get a total and cause-specific mortality, which will help us determine some of the different fractions of deaths. And then the requirements are also quite simple after the initial high investments of an SRS. And so what does that mean? We went on to talk about the comparative cost. If we compare what is currently happening versus the implementation of an SRS, what would be the final verdict? So for instance, the National Population and Housing Census in Ghana, the annual cost was in the region of about 4.5 million. And over a 10-year course, it's going to be about 45 million. If you look at the DHS, we spend close to 10 million for each round, and USAID make close to 5 million contributions every year. look at a CRVS. So running a CRVS from our government appropriation bill, like what we see every year, we're spending close to 11 million as a country over a period of 10 years. If we implement an SRS, our annual cost would be in the region of 0.7 to 1.1 million if we use the Mozambique example. And then over a 5-year period, we're moving towards a 5.5 million. And then over a 10-year period, we're doing about 11 million. What this means is that these values are relatively lower compared to the other surveys that we are currently looking at as a country. And so if we look at the value proposition, if we look at the cost benefits, you realize that we'll get more implementing an SRS compared to investing heavily on some of these things. And so one of the cases that we made was that, look, if we're going to spend 10 million over a 10-year period for a DHS compared to spending 7.8 million to 11 million for an SRS over a 10-year period and getting more value, more data that would allow us to make decisions in real time, then it may be better to invest in an SRS. We also looked at what success would look like, and we hinged that on 3 pillars. For an SRS to be successful in Ghana, we're looking at it being data-driven, decision-making tool. It also being one that would contribute to our health security as a country, and then also improve the CRVS system. And above all of this, it should be able to provide our partners and then other global stakeholders accurate current measures of the core population indicators. So giving partners the needed indicators, data to be able to measure their program performance and impacts, as well as provide the country with the right denominators, and they're helping us to track our SDG-related indicators as a country. We looked at these pillars, tried to provide some examples to USAID at the time. And so one of the things is, so for instance, if you look at the pillar 1, which is data-driven decision making, if you look at the hypothetical case where an SRS is implemented in the country, at the moment, you may not be able to have these different fractions of the causes of death across the entire country to a lower level. But with an SRS, we will be able to tell at the national level, these are the leading causes of death. At the regional and then the sub-regional level, we'll be able to provide that kind of a data with an SRS. If you look at the case for Mozambique, they were able to provide this cause of death data by age groups, which became very useful, extremely very useful for planning as well as resource allocation and then program intervention design and then implementation in the country. We presented some of these examples to Ghana, to USAID at the time, to be able to make the case that an SRS would be able to provide us this kind of information. Also, these are other examples that we picked from the Mozambique case, where they were able to provide the different causes of deaths and then how that has changed over time. And again, Ghana would be able to benefit with an SRS for something like this. This is an example from Sierra Leone, where they do the different deaths across the different age groups. And again, like I said, this was a revelation when they realized that more adults were actually dying from malaria, contrary to the conventional thought that children were the only people who were mostly affected by malaria. And all of these resources are available for us to be able to look at in the Viva platform. So an SRS should be one that should also be able to contribute to our national security. And at the time, we also try to make that case very strongly. So the contribution would be, it will help us determine outbreaks very early to be able to put in place the right measures to stop disease threats. We'll also be able to help us timely measure our accessibility during pandemics. So this has always been a case where when COVID struck, up to date, there's still a struggle for most countries to be able to determine the excess mode. With an XRS put in place at the time, we would have been able to determine all of that and calculate that kind of information. For an SRS also, it's an opportunity to be able to improve our our CRVS system. So at the moment, Ghana's CRVS system, deaf completeness is below 40%. And so what that meant is that if we have an SRS put in place, it will serve as a deaf notification platform to be able to pick all devs that are happening within the communities and then linking that up to the CRVS system for these devs to be registered. And that would help us address the low completeness that we are seeing currently in the country. At the moment, the CRVS system in Ghana also does not collect cost-specific data. So again, we'll be able to add that innovation onto our CRVS system to be able to collect this kind of data moving forward, making data more available to be able to provide us a more complete picture of what the leading causes of deaths are within the country. And this data would also be collected and stored in the nationally mandated entity that is the BDR system. There are a lot of opportunities for SRS innovation and improvement using an SRS, and we've seen some of these examples from Mozambique. This data currently shows that kind of information, where they are comparing the deaths that are being registered across the different provinces in Mozambique. And we made a case that similar things can easily be done in Ghana to be able to pick up some of these deaths, improve the notification to the CRVS. That would facilitate death registrations and improving the coverages over time. And then, of course, we want to also stick to global best practices where we want to make sure that most of our data around mortality, the CRVS system is strengthened enough to be able to collect complete data for government decision-making processes, as well as integrating our digital data platforms such that there will be that kind of interoperability across the different systems. So Ghana Health Service will not only have to rely on their DIMS data, that's the DHIS2, but then they can also share and then have information that is coming through the CRVS system to be able to make sure that we have more complete mortality data across the country. What are the cost-benefit analysis that we did and in return on investment? So at the time, we looked at the different partners within the space that stands to play very important roles and would benefit from an SRS. And then the big question was, what would be a value proposition statement for these stakeholders? So for instance, if you look at the Ministry of Health, with an SRS, they would be able to use their own mortality data to determine the burden of diseases and deaths, to be able to prioritize, plan, and then monitor their policies and programs. If you look at the development partners, they would be able to use reliable, timely population data that would help them prioritize, plan, and then monitor the impact of their health programs such that they would be able to actually address questions around equity. Are their programs actually reaching the people that they need to reach or not? And so we looked at the different stakeholders, and then we had very brief value proposition statements on what an SRS could do for them. We looked at operational efficiency of an SRS. We looked at issues around what are the main cost drivers. And I'm rushing because of the time. I know Steven is on to also come on. So with the cost drivers, we discussed what would be the biggest cost drivers for an SRS in Ghana. And it's always about the initial investment that has to be done. If we look at the example from Mozambique, the initial investments was around 2 million. A majority of this money was coming up from the startup cost. So infrastructure, technology, and training, that took a lot of the amounts. And then the recurring operational cost was about 1 million. For Hills Sierra Leone, they had an operational cost of about 780,000 US dollars. What this meant for Ghana was that if we are able to start with an SRS and we're able to initially implement, set up the infrastructure, technology, and then train all that needs to be trained, we would be able to beat down the operational costs if we have a more integrated leveraging from what existed as a country. And so this was very clear with USAID at the time that the initial cost usually will take that much, but then the operational costs, the routine expenditures may be managed and be done more efficiently to be able to reduce the costs. We did a risk assessment and then also look at the operational and then the mitigation strategies that we need to be careful about as we move forward with an SRS implementation in the country. So we looked at the institutional rules because we have multiple stakeholders coming on board. What would be individual roles? We looked at the government structure. We looked at government buying as well as the stakeholder buying. Those stakeholders who are already within the space, would they be interested in investing in an SRS moving forward or not? What would be the benefits if they have to put their money in an SRS? We looked at the technical risk, and then we thought about the sample size. Again, this is a thorny issue. We looked at the completeness of the vital events notification, so the community structures that will be put in place to make sure that we are collecting all deaths and we are able to follow these deaths and then determine their causes of deaths. We also looked at the data. What would be the data issues that would come up? How do we ensure that we have a supportive system that would help make sure that all the data systems are up and running and then they are interoperable with the existing systems? Financial risk, of course, have to do with our donor coordination. So as a country, we do have a development partners meeting, and these meetings happen every month. And so one of the biggest things that we wanted to do as a country was to continue to discuss the importance of mortality surveillance at these meetings. So USAID took the lead by trying to coordinate all their development partners, as well as also engaging government to start thinking about domestic budget allocations to be able to support mortality surveillance across the country. And so these were some of the most important things that we had to do at the early stages. So as I conclude, making sure that an SRS succeeded in Ghana was more of a balancing act. How do we ensure impacts? How do we ensure government's ownership? And then how do we ensure that there's leadership to be able to move the country towards the right direction? And then also making sure that once an SRS is established, it's sustained over time. And so SRS has proven to be for purpose, and it's also really recent in country, we recognize that. But then there are already results that we can see from Mozambique, Sierra Leone, and then in the past from Tanzania. And we see that as a solution that would help us address the many different gaps that we currently see within our health system. Also, we realize that there will be a variety of beneficiaries from an SRS, both at the national, the regional, the district, as well as our development partners. And so we feel that as a country, if we're able to implement an SRS, we're better placed to be able to address some of the data gaps, make sure that the equity question of whether our programs are reaching those who most need it or not is addressed. Thank you very much. I'll stop here. And if there are questions.
Thank you, Williams, very much. Yeah, I think that's very impressive of the work done and a very compelling case for SRS in Ghana. I think it would be a fantastic resource and an example of how to prepare such an investment case for the planning grant countries. And as you said at the beginning, we prepared and shared similar templates for an investment case pitch deck, which was actually based on this one and complemented with some other resources. So I think it's a great example of how to utilize this resource now for the next steps. So thank you very much. I think I see already a question, or sorry, a comment from Kingsley, but let us move on maybe to also the presentation for Stephen and then take the questions at the end.